Well, good afternoon or good evening, everyone, depending on where you are joining us from. My name is Hilly Page with the Family Heart Foundation. We're going to give it another minute. We've got a lot of people registered for this important discussion this evening. So I'm going to give it a minute for folks to make their way in through Zoom, and we'll kick off in just another minute. Well, this is great. We're 2 minutes past, and we've got over 100 people already online. And so, a big thank you to everybody who has joined us this evening. Again, my name is Hilly Page. I'm the Chief Innovation Officer for the Family Heart Foundation. And thank you for joining tonight's webinar, Family Heart webinar, entitled New Dyslipidemia Guidelines Aligning Science and Care. Now, it's been 8 years since the update from the last time that the cholesterol guidelines were updated in 2018. And so there's a lot of new information in there, new recommendations, new insights, new science. And I'm so excited that my good friend, Dr. Payal Kohli, is joining us for this conversation. I'll do a longer introduction of Dr. Kohli in just a minute, but she is a preventive cardiologist in Denver and is just not only a gifted clinician, but a wonderful educator. And Dr. Kohli always does a great job of taking the complex and boiling it down into something that is simple and understandable and answering questions. So, Dr. Kohli, welcome, and thank you very much for joining us this afternoon. It's really a pleasure. I'll
Pleasure.
go ahead and on the next slide. So one of the things we love to do with our webinars is answer as many of your questions as we possibly can. And so if you do have a question, if you would put it in the Q&A section of Zoom. So we don't have the chat function enabled, but we do have the Q&A section. So if you can search for that and put in your questions anytime during the webinar, we'll definitely get to as many of those as we possibly can. On the next slide, I wanted to tell you just a word or two about the Family Heart Foundation. So the Family Heart Foundation was founded in 2011. We're a nonprofit patient advocacy organization, and the mission of the organization is to save generations of families from heart disease through timely identification and improved care of the two most common inherited cholesterol disorders, and that would be familial hypercholesterolemia, or FH, which occurs about 1 in 250 individuals with a diagnosis rate of around 30%, and elevated lipoprotein A, or Lp(a), which occurs in 1 in 5 individuals, but only has a diagnosis rate of around 1%. We focus on research, advocacy, and education to drive change and empower families to navigate their own health. And you see our website down there below, familyheart.org. Please check us out. We've got lots of resources on there. On the next slide, we always encourage folks to follow us on their favorite social media platform. And also, if you sign up for our newsletter, we have a lot going on at Family Heart, a lot of webinars, a lot of new educational resources. And so if you want to stay in the know, please give us a follow. On the next slide, I always say this slide is just an indicator that even nonprofits have lawyers. And so this is a medical advice disclaimer, which basically says that Dr. Kohli cannot give you individual medical advice tonight during the webinar. So we hope that these webinars are informative, that they're thought-provoking, but it is so important that you follow up with your own clinician if you have things that you want to discuss. If you don't have a clinician, you can connect with the Family Heart team of care navigators, and we have a specialist map, and so we can connect you. We have over 600 healthcare practitioners on our specialist map. But again, this is really informational, thought-provoking, but not specific medical advice. On the next slide. So who is at risk for a heart attack? One of the things that we always focus on at the Family Heart Foundation is not only is cardiovascular disease the leading cause of death in America, but it's more than 80% preventable. And this is a picture of one of our Family Heart ambassadors, Aditi. Her father had a massive heart attack at the age of 59. Aditi, who actually just did a webinar for us last night, had a stroke at the age of 27. And so high LDL cholesterol can have an impact at any age, and that's why it's so important to know your risk. Last September, we launched a new website called the LDL Safe Zone. A lot of different videos, tools, resources on there. Everything you ever wanted to know about LDL cholesterol can be found on the LDL Safe Zone. You can go to ldlsafezone.org. One thing I'll point out on the next slide in particular that is our most downloaded slide or most downloaded tool right now is the LDL cholesterol action plan tool. And so this was just updated based on the new dyslipidemia guidelines. And it's a two-page form. On the front side, there's a flow chart that allows you to identify based on your level of risk, what should your LDL cholesterol goal be. And then on the back side, if you flip it over, there are a lot of different recommendations. All the different therapies are listed there. And so this is just a great resource if you want to take action based on what you hear tonight. On the next slide, if you don't know your numbers or if it's been a while since you got yourself tested for your LDL cholesterol or your lipoprotein A, the Family Heart Foundation launched a program in September of 2024 called Cholesterol Connect. This offers free at-home testing through the Family Heart Foundation. So it's a test kit that you order. It comes in the mail. It's a finger stick test. And you're able to test yourself for your LDL cholesterol, your lipoprotein A, and you have the opportunity to connect with one of our Family Heart Care navigators. Since we launched the program, we've sent out over 30,000 test kits, and you can get yourself a test kit at the website below there, www.cholesterolconnect.org. On the next slide, you see this is what the test kit looks like. It comes in the mail. It's simple finger stick test. And in the lower right is the QR code. If you want to scan that with your phone, it will take you right to Cholesterol Connect. And again, this is something, if you haven't tested yourself recently for your LDL or your Lp(a), it's really a great opportunity and totally free through the Family Heart Foundation. No insurance needed, totally free through the foundation. On the next slide, so we had just two polling questions before we get into the main presentation. We always try to do this to kind of level set and see where the audience is. And so we'll go ahead and launch the first one, which is, have you had your LDL cholesterol checked in the past 12 months? And that's a yes, no, or not sure. And I think you'll even get a chance to respond to the second polling question, which is, have you ever had your lipoprotein A or Lp(a) tested? And that's a yes, no, or not sure. So feel free to take a moment to answer both of those. And Susan and Jackie on the back end will tabulate the results, and we'll take a look in just a minute when they are available. But again, the first one, LDL in the last 12 months. And the second one is, have you ever had your lipoprotein A tested? So it's great to see that, wow, 95% of individuals have had their LDL cholesterol checked in the last 12 months, and 88% have had their Lp(a) tested. Now, just an anecdote, we go to a lot of physician meetings and we do lipid testing at the booth at these different healthcare practitioner conferences. And we find in general about 40 to 50% of clinicians haven't had their LDL tested in the last year, and about 80% have never had their Lp(a) tested. So we've got a very knowledgeable group online with us this evening, Dr. Coley. And on the next slide, I just want to go ahead and introduce my friend, Dr. Pyle Coley. She has such an amazing bio that I would do a disservice if I just didn't read it to you quickly, but her expertise is really incredible. She's an internationally recognized expert in cardiovascular medicine. She's an associate adjunct professor at both Johns Hopkins and Duke, and the founder and medical director of Cherry Creek Heart in Denver, Colorado. She graduated from MIT with a perfect GPA and from Harvard Medical School magna cum laude, and did her internal medicine residency at Harvard and her cardiology fellowship at UCSF in San Francisco. Dr. Coley specializes in general preventive cardiology and in cardiometabolic disease. This is one of the most impressive things, I think. She's the 2024 American College of Cardiology Gifted Educator of the Year, and that was so well deserved, and the 2022 American College of Cardiology Cardiologist of the Year. And she's also an on-screen television medical personality with over 3,000 television appearances, both locally and nationally. And currently, she's the medical expert at 9 News in Denver, as well as on radio station KOSI 101 in Denver. So if you're lucky enough to live in the Denver area, you may have seen Dr. Coley on the news. So with that, Dr. Coley, thanks again for joining us, and I'll turn it over to you, and then we'll get to the Q&A.
Thank you so much, Hilly. And I really want to thank you all for your time today, because someone once told me that time is your greatest gift, because once you give it away to someone else, you never get it back. So I want to thank you for this gift of your time that you're giving me tonight. I want to congratulate you, based on what Hilly said, for being such an educated and empowered audience, because I do believe that one of the biggest challenges that we have as people, as clinicians, is how do we not just live longer, but how do we live better? And as Hilly alluded to, the American Heart Association tells us that 80% of heart attacks and strokes, which is the most common thing that's going to happen to any of us or any of our family members or loved ones, are preventable with the correct risk factor management. So tonight, I really want us to anchor to that statistic, and I want us to think about how we can know our numbers, know our risk, and really put it within the context of these new dyslipidemia guidelines so that we don't just live longer, we live better, we age better. And that's the goal of tonight, is to really help you understand LDL, low density lipoprotein, which is the bad cholesterol, but perhaps also understand some of the other components of your lipid panel, the non-HDL cholesterol, the HDL cholesterol, the triglycerides, what all of those mean, and really what we need to do in order to control those. So as I'm talking tonight, start to think about your own numbers, because it sounds like most of you have had your numbers checked, and then start to put yourself in risk categories or risk boxes, because that's how we think about it. We say, okay, we're trying to get a crystal ball, look into the future, and predict what your risk of having a cardiovascular event is going to be, not just in the next 10 years, but over the course of your lifetime. And how does LDL cholesterol really play into that? So let's talk a little bit about the new dyslipidemia guidelines. But before I get into that, I do want to give a shout out to the Cholesterol Connect, which I used myself just very recently in order to get my own LDL and LP little a checked as well. Of course, I do my LDL at least once a year because I like to keep an eye on it. But it's a really easy to use test. So if you haven't already ordered your kit or done it for your family members, you ought to do that. And I even ordered some last year as stocking stuffers for some of my family members at Christmas. So think about using it as gifts as well. So I'm going to start just by kind of laying out the landscape. And I sort of alluded to this already, which is that, we think a lot about cancer screening. We think about mammograms when we turn 40 to look for breast cancer. We think about colonoscopies when we turn 45 to look for colon cancer, which is all very important. But what we've forgotten is that there's no magic test we currently have for atherosclerosis. Now, certainly there's a test called a calcium score, which is an X-ray of the heart. There's also the cholesterol panel that we're going to talk about tonight. There's the LP little a, there's the risk calculators. There's even a test called a polygenic risk score, where they take your genes and try to predict your risk of having heart disease. But it's not as easy as looking for colon cancer or breast cancer when it comes to heart disease. It's much more complicated. And yet it's the most common thing that's going to happen to any of us, men, women, US, worldwide. And it's the most treatable thing. It's one of the most preventable and modifiable things that might happen to us. So I really want us to start to think about a train that's headed towards a destination. And your train in your 40s, 50s, and 60s is going on this track. And you make a tiny little change in the track, a few inches perhaps, and your train ends up in a whole different destination 1 or 2 decades later. That's how I want us to think about LDL cholesterol, where we're modifying the trajectory of our train, which is determined obviously by our risk factors, our family history, our age, our gender, our cholesterol, our blood sugar, our blood pressure, all of these different factors. And we're taking control of our numbers so that we're not just a passenger on the train, but we're actually the conductor of the train deciding where it's going. So be empowered with your LDL and realize that's because, again, heart disease kills more people than essentially everything else combined. Now, if you ask me, Dr. Coley, what's the most important thing you do in clinic? I would have to tell you it's your cholesterol management. And I'm not just saying that because I'm a preventive cardiologist and not just because the seminar is on cholesterol, but they've actually looked at this. So this is data from a study called the InterHeart study, where they looked at all the things that cause heart disease. Here we have alcohol, diabetes, exercise, diet, high blood pressure, being obese, obviously mental health issues, smoking, and cholesterol. And what they found and reported, which was surprising but not so surprising, was that reducing lipids has the greatest impact of essentially all 9 of the modifiable factors for heart disease. Now, of course, you see on here your age is not modifiable, right? Your family history is not modifiable. Your genetics aren't something you can change. But these are things that are in our control that we can modify, change, screen for, detect, and treat. And if you think about what gives you the biggest bang for your buck, it's really thinking about those lipids. So I'm really happy that you've started to check your lipids and think about how to modify them, because when you think about reducing your risk for having a heart attack, lipids is one of those most important factors. Now, one of the things that's been really frustrating as a preventive cardiologist is often you'll get your lipid numbers back from Quest or LabCorp and they'll say normal, and you'll have this normal range. I want you to stop looking at that normal range on that Quest or LabCorp requisition, and instead I want you to think about your underlying risk. Use a calculator called the Prevent Calculator, which you can find online to calculate what your risk might be, and talk to your doctor about whether or not you're at the target that you need to be at. Because what normal used to be 10, 15, 20 years ago is no longer normal. Because what we've realized is that the even modestly elevated LDL cholesterol for most of your life is associated with substantial risk of having heart disease or having plaque or deposits of cholesterol in your arteries. So this is really nature helping us out, doing essentially an experiment for us, and giving us information about science and how disease happens. So I told you the most common thing that's likely to happen to any of us is that we get blockages in the arteries. Now there are people who are born, and that's that purple line at the bottom, that have these genetic mutations that keeps their LDL cholesterol very low from birth. And so LDL cholesterol comes from two sources. The majority of it is actually synthesized in the liver, about 75%, and about 25% is modified by our diet and lifestyle. And the two pathways talk to each other. But notice that the majority of it is actually genetically determined. So you don't have to be skinny or heavy or tall or short, or, it doesn't matter what race you are. Your LDL cholesterol can be elevated. And I can't tell just by looking at you whether your LDL cholesterol is elevated or not. So it's really important to check those numbers so that you know early on in life which of these four graphs you fall along. So the bottom graph, you're born with a little happy accident of nature that essentially turns off either LDL cholesterol production or increases the clearance of LDL cholesterol from your bloodstream. So you can see here that their cumulative cholesterol years of exposure are much lower, which means they actually have a much lower risk of having atherosclerotic cardiovascular disease, or those plaque depositions in our heart, in our, blood vessels going to our brain, in our legs, in our aorta, all over in our body. On the other hand, if you look at the red line, and that's what Hilly was talking about, these are patients that are born with a condition called FH, hypercholesterolemia, and you can either have one bad copy of a gene that makes your LDL numbers go way up, and that's called heterozygous FH, or you can have two bad copies of the gene, one from each parent, and that's called homozygous FH. And you can develop that mutation spontaneously. So I don't want you to necessarily walk away thinking that just because your parents didn't have high cholesterol, you're not at risk for it. Certainly if they had it, you're higher risk for it, but that doesn't mean that it can't occur spontaneously. So now you see the opposite effect. The LDL volume on your little stereo is turned up from birth, and you get premature heart disease. You get cardiovascular events like heart attacks and strokes. And, we have blood vessels in every organ in our body. So we get all kinds of adverse events that occur as a result of this. And unfortunately, many people even prematurely die. Now, Hilly showed you a picture of Aditi, who had a stroke at a very young age. Her father had a cardiac event at a relatively young age as well. And so these would be people that you would be more concerned might potentially have a condition that genetically elevates their cholesterol. So we know that FH, which is a genetic disease, can usually, occur for many different types of mutations. But one of the most common mutations you see is that the LDL is not being cleared from the bloodstream. So if our LDL doesn't get cleared, go into our bile and come out in our stool, it ends up sticking to the walls of the arteries and causing blockages, right? And the more blockages you have, the more blockages you get, because blockages beget blockages. But what it creates is an inflammatory reaction in the wall of the blood vessel that then causes more cholesterol to stick and more cholesterol to stick, which makes the blood vessel wall a little bit stickier, and so on and so forth. Now, it's important to note that most people have the preconception that atherosclerosis or blockages are a disease of midlife. Well, I don't need to worry about that right now because I'm in my 20s and 30s, and that's a disease you get when you get older, right? Wrong. So you can actually start to develop something called a fatty streak, which are early deposits of atherosclerosis as early as your late teens or early 20s, depending on your cholesterol years of exposure. So how high your LDL is and how long it's been elevated. So people who have kind of moderately elevated LDL cholesterol, potentially in the presence of other risk factors, can start to get atherosclerosis pretty early in their life when we sort of think of them as healthy. And that's why we as clinicians are now shifting that screening earlier and earlier and really emphasizing, whether it's to your kids or grandkids or for yourself, if you're in your 20s or 30s, it's time to pull up your socks and make sure you get your LDL cholesterol checked. Now, FH can occur in 1 out of 112 people, and we know that it's both underdiagnosed and undertreated. And that's a problem both with the system, but also with the clinicians, because we don't always know that it can happen. We don't always look for it. And I like to say LDL kind of puts a blindfold on, right? Us, because unless you check for it, you don't know exactly what's going on, and you know that it is likely to lead to premature atherosclerosis in these patients. So I've been talking a lot about LDL, low density lipoprotein. I want you to think of this as sort of, the bad guy. My nephew is 7 or 8 years old. He loves Batman. And so the bad guy in Batman is LDL, right? But there are many other bad guys in Batman as well, right? It's not just the LDL. We have the LP little a, we have inflammation, we have obesity, we have diabetes, and those are all the other kind of evil characters in that cartoon. But I want to take you through why we as cardiologists have really decided to shift the needle and think about lowering LDL more aggressively and doing it earlier in your life in order to really change the trajectory of your train. So we know that many, many studies over the years, and these are many different types of studies, randomized trials, which we know is one of the highest quality evidence. You get a placebo, you get this. The people that got the treatment that lowered their LDL, less heart attacks, less strokes, less cardiovascular death. Mendelian randomization studies. Nature does a happy accident, like I told you, increases your LDL. You go on to have premature heart disease and have bad outcomes. Nature makes an accident, decreases your LDL or turns it off in some cases. Your LDL clearance is improved, so you have less LDL circulating in your bloodstream. You are protected from heart disease. And then, of course, many observational epidemiologic studies for people, for example, people who have lifelong low LDLs because of the diets that they follow and such, they have very low incidence of heart disease. So I want to be clear, LDL is a causal factor in atherosclerosis, and it's directly causal with the dose-dependent relationship, meaning the more LDL you have, the more heart disease you're going to have, independent of your other risk factors. So that's why it's really become our primary target. In fact, the ACC and AHA, the American College of Cardiology, and the American Heart Association have gone and made goals so that your doctor and you know where your LDL needs to get. Now, your goal is really based on your risk category, and that's what we're going to review in a second here. So basically, I want you to start on the right side of the screen because that's the latest update, and then I'll kind of fill in where we were before. So the 2026 ACC-AHA guidelines tell us that lower is better. So the lower you get your LDL, the better. So what you're essentially going to do is first ask yourself the question, have you ever had a heart attack or stroke? If the answer is yes, you're in what we call the very high risk cardiovascular disease category because you've already had a manifestation of that blockage declaring itself, right? So that blockage was inflamed, it got angry, and it ruptured inside your artery, created a blood clot. That caused the heart attack or the stroke. So you're in the highest risk category, and your LDL goal is that number on the bottom, less than 55. Okay, that's the least you can, that's the least threshold you can be. So if you go even lower, it's even better. So if you get to 50, it's even better. If you get to 45, that's even better. Now, keep in mind, it's not just getting to 55. We also want to do something called a reduction, a delta LDL. So how much we drop your LDL is also important. So let's say that you had your heart attack or stroke, God forbid, with an LDL level of 70. Then 55 is not enough, right? Because your blood vessel declared itself at 70, it told us as clinicians that it's angry. We've got to do better in order to stabilize that blood vessel and also the other plaques from rupturing inside your blood vessel. You want to make sure you drive that LDL down. So there I do a delta 50%, which means if you came in at your event with an LDL of 70, I'm going to drop you down to 35. So those are people who've already had clinical events. Next is the patients who are considered sort of subclinical atherosclerosis, meaning you have a really high calcium score or you're diabetic with lots and lots of risk factors. And so you're basically a setup to have blockages. Or, like I said, you've already had a CT angiogram or a calcium score that's told us that you have a lot of plaque already in your arteries, but it hasn't ruptured or declared itself yet with a heart attack or a stroke. So those are kind of, I would say, the intermediate risk patients in my mind, because you think about, okay, they're kind of headed that way. They're not quite there. Their ASCVD has not declared itself, but certainly we need to do something so it doesn't become a heart attack or stroke. So those are people you want to at least get less than 70, and you want to do that delta 50%. But there's an option in the guidelines to even get those people to less than 55 if they're very high risk. So I really want you to think about your risk categories again as I'm going through this here, because if you're a diabetic who's considered high risk, and high risk diabetics are those that have had diabetes for greater than 10 years, or those that potentially have insulin dependent, or they have an apathy, then you may be one of those people that would benefit from this. Now, I'll make a quick caveat that the data and the guidelines have a little bit of a disconnect. And Hilly and I were just talking about this when we saw each other in Houston a few weeks ago, which was essentially that the guidelines came out. And then right afterwards, there was this very high profile trial that came out that showed significant benefit to LDL lowering in patients, like I mentioned, who are diabetic and have multiple risk factors. And based on that trial, the FDA actually approved a medication to reduce LDL down to very low levels for diabetics who are high risk. So there's a little bit of a disconnect between the guidelines and the clinical science, because there's always a lag when it comes to it. But strictly by the guidelines, if you are somebody who's a high risk diabetic or you have multiple risk factors, you can talk to your doctor about whether it makes sense to lower your LDL to less than 70, greater than 50%, or perhaps even go less than 55. And then the top is the people who have never had a heart attack or stroke. They necessarily don't have too many high risk features, but based on this calculator called the Prevent calculator, which again, I want you to Google and put your numbers into, you want to get your LDL below 100. So to be clear, if you have any kind of risk factors for heart disease, and that's again your borderline or intermediate risk, your LDL should not be triple digits at all, ever. And that's starting very early in your life. You want to get it down, because that's how you're going to reduce your risk of developing heart disease later. Now, if you kind of look backwards on the left side of the screen, you can see that over time, there's really been an evolution where we've gotten to the point of lower is better. I will point out that in Europe, based on the 2025 ESC and EAS guidelines, extreme cardiovascular risk, we're actually getting them down below 40. And that usually means patients who've had multiple events. So they've had multiple heart attacks, multiple strokes. They continue to have these what we call vascular events, where you have some kind of a plaque rupture that causes a blockage inside your artery. And so those are the patients you want to be really aggressive about and get them down even lower, because that blood vessel blockage is declaring itself at those other LDLs. So the gist of the guidelines is really lower is better for longer and faster. And I want you to really think about which of these risk categories you fall into, with the caveat that if you're somebody who's kind of not yet developed full-blown heart disease, but you have kind of borderline risk, then you may be someone who wants to talk to your doctor about exactly where your target is. Now I want to take you through the evidence of this trial, which was the Easy Pave trial. And that really looks at, okay, let's get the LDL down, but how much should we get it down? Because over the years, you'll notice that our LDL goals have been shifting lower, 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 lower. When I was in residency, our LDL goal was less than 130 for people who had a heart attack. Then it became 100. Then it became 70. Now, as I just told you, it's less than 55. And in Europe, for people who are extreme risk, it's now less than 40. So this trial was really an interesting trial. It was an open label randomized superiority trial. It took about 3,000 patients who all had heart disease. And it said, okay, let's see, do you do better if I get your LDL less than 70? Or do you do better if I get your LDL less than 55? And it followed them for 3 years. And you can see here that the curves start to separate pretty early, right? Within a few months, which starts to suggest to us that there is a significant benefit. And you can see the blue curve is the ones that got lower, that had intensive LDL target of less than 55. And take a look at how much the relative risk reduction is on the right-hand side of the screen. You're reducing the risk of having a heart attack by 54%. It's cutting it in half. And you're reducing the risk of revascularization, which means like a trip to the cath lab to get a stent or something like a bypass surgery, by 37%. I mean, these are incredible risk reductions, and all you've done is really move the LDL target a little bit lower, right? So that really does reinforce that hypothesis that I've been talking about. And this is in patients, again, who've already had a heart attack or stroke, that it is really important. Lower is better for longer and faster. And so we really want to start thinking about screening people earlier. And, I mentioned grandkids. So if you have any grandkids, then you want to make sure that their pediatrician is starting to screen them if they're average risk between the ages of 9 and 11. Certainly, if you have a family history, then you want to start to screen, as young as 2 years old, just to make sure that you catch that elevated cholesterol really early so you can start to act upon it. Once you screen them as a kid, if the kind of numbers look okay, you check again at 19. Now, this is a hard thing to do, right? Because what are we at 19? We're in college and we're goofing off and we're busy at frat parties and sorority houses and what have you. We're not really thinking about cholesterol. But that's where education, knowledge, empowerment really does play a role, because a lot of also adult doctors who treat 18 or 19-year-olds don't really think about cholesterol. They don't think about cardiovascular risk, but that really is the time to start to think about cardiovascular risk. And then based on that cholesterol, you want to calculate a prevent score. And then, of course, as we've talked about, once you've kind of gotten into the adulthood range, you want to target your LDL based on your prevent score equation. So your LDL should be less than 100. If your risk of having a cardiovascular event in the next 10 years is less than 10% based on the prevent calculator. It should be less than 70 if the prevent calculator says you're greater than or equal to 10%, if you have a family history, or if you have diabetes with multiple risk factors, or if you have a calcium score that's positive. And the FH patients also should be less than 70 because their lifelong exposure is really high. And then it should be less than 55 if you've gone ahead and had a clinical event like we talked about. And then now we're saying it's even okay to give statins and LDL reduction to patients even when they're older. And there's really good data that's come out after the age of 75 that you're not causing risk, you're not causing muscle loss or sarcopenia or all the things that a lot of times clinicians worry about, but you're actually reducing their risk of having cardiovascular events, which we know happen more as we get older. So it used to be we would say, oh, after the age of 75, let's not think about treating older patients because their life expectancy is limited. But that's, of course, not the case anymore. So we continue to treat people a lot longer into their life, certainly tailoring that therapy and tailoring the interventions to what they need. So speaking of interventions, let's talk a little bit about essentially what you can use to lower your LDL, your low density lipoprotein. And as I said, most of it is genetically determined. And so most people, as they start to get into mid ages at 40 to 60 years old, their risk starts to go up just from their age, right? So even if all your numbers look good, as you get older, usually men over the age of 55, women over the age of 65, just the age itself confers a risk of cardiovascular disease. We know with women, menopause is another inflection point that certainly can increase your risk. It can increase your LDL cholesterol. It can increase your blood pressure. It can increase your stress hormones, all of those types of things. So let's talk a little bit about what the options are to treat. But before I do, I just want to remind you of that mantra one more time. Ready? And you guys all have to say it back with me. You're not able to unmute yourself, but I want you to say it out loud so that you remember this for yourself and for your doctors. The 3 principles of LDL cholesterol lowering. The lower the better, the faster the better, and the longer the better. So it's not just getting them there, it's getting them there faster, because we actually have very compelling data that tells us that 2 people get to the exact same LDL, the person that got there faster actually has a lower risk of having adverse cardiovascular events as compared to the one that took 2 or 3 or 4 more years to get there. So we've really decided that it's an urgent situation to treat our LDL. And I have to tell you, no patient has ever come into my office and said, Dr. Coley, my LDL hurts, right? Because it doesn't hurt. It doesn't create noise. They do tell me their back hurts. They tell me their legs are swollen. They tell me they have palpitations. They tell me they have headaches, but nobody complains about LDL. So it really is up to patients and up to providers to think about checking it. The lower, the better, the faster, the better, and the longer, the better. And really what this is part of a comprehensive approach to reducing and stamping out heart disease, right? Which I think the Foundation is such an incredible organization because it talks about saving generations of people, right? I mean, how incredible is that? What you're doing today doesn't just impact you, it impacts your kids, your grandkids, their grandkids, so on and so forth. So we really want to make sure we realize that cardiovascular health is really determined by all these different factors, some within our control, some obviously outside our control, but we want to think about starting to screen for heart disease in childhood, right? Because we know that that's a natural part of aging. We know that that's how disease happens, and we know that we want to live better, not just longer. So that's called primordial prevention, where we really start to think about screening all the way from childhood to early adulthood, starting to treat very aggressively, not just cholesterol, but all of the other risk factors. And the American Heart Association calls this the life's essential eight. And so if you are curious, you should go to their website and calculate the Life's Essential 8 score, which tells you a little bit about what you're doing well on in terms of these modifiable risk factors and potentially what you could do better on. Now, a few things that we haven't talked about that certainly, weigh into whether or not people get heart disease is stress, right? And there's not a great way for us to assay the stress and the mental health of people. Sleep is a big part of it, and certainly we're trying to aim for that 7 to 9 hours a night of sleep for most people. Environmental exposure and pollution. That's something we don't talk about often enough, but the World Health Organization says it's one of the most modifiable risk factors for cardiovascular disease. And unfortunately, many of us don't even think about the air quality index when we leave our house. But I do want us to start to think about it because, again, it's really important to start this process very early in our lives and to help our family members to understand that primordial prevention is the way of the future. And that's how we're going to think about heart disease moving forward. I have patients who ask me all the time about what type of diet they should eat. And you may or may not be aware, but the American Heart Association just released new dietary guidelines, which have very much emphasized that you need to eat a plant-based protein diet. And that's really important. Now, this can be confusing to some people in the setting of the new food pyramid that has also been released by our administration more recently, where there are a lot of things like butter and beef tallow and such that are emphasized as potentially heart healthy. But really, that's not true. The data doesn't support those saturated fats. The data really does support a plant-based, unprocessed food diet. And I'm not talking about fake meats because that's vegan junk food. I'm talking about real plant-based proteins like beans and lentils and tofu and nuts and all those delicious things that we have to put in our diet. So really the way to think about your plate is you want half of it every meal to be fruits and vegetables. You want a quarter to be some kind of lean protein. As I mentioned, if it's a plant-based protein, that's an A plus, but a couple times a week, if you want to eat salmon or chicken or some other lean fish, that's very much a part of the Mediterranean diet. And then you want a quarter to be some kind of whole grain. And if you start to do that, add a little bit of course, fiber, also add a little bit of dairy so you get some probiotics. These are all really good ways to make sure that you're getting a really nice diet that's associated with lowering your heart disease risk. So it's been a really exciting time in the past decade, I would say, because we've had all these new tools in our toolbox. So if you can see, there was kind of a lag between the 70s and the early 2000s where we really only got statins. So bile acid sequestrants are really old drugs that kind of, bind the cholesterol. We don't really use those very often anymore. And statins were the kid on the block in 1987, and they were a huge breakthrough, right? Because they changed the trajectory of heart disease. They changed the trajectory of heart attacks. It used to be that if somebody had a heart attack, you would put them in the intensive care unit, turn on classical music, and essentially wait for their heart attack to complete, and then just hope that they don't have another. When statins came on the scene, and of course, stents and opening up blockages, those two interventions really changed the trajectory of heart disease so that people didn't die from their heart attacks. They had a heart attack, they got their blood vessel open, they got put on a statin medication, and hopefully prevented the next heart attack. But you can see in the last decade, we've had a lot of new medications that lower your LDL cholesterol, and they do it in ways that are more targeted and smarter. So as an example, evolocumab and alirocumab are these injection medicines, and it's the first time we used injections in cardiology. Now, of course, injections are all the rage with the GLP-1 medications. But they're an antibody, and they're an antibody that makes it so you clear more LDL cholesterol from the bloodstream. So they target the LDL receptor, which is the the thing that picks up LDL cholesterol from the bloodstream. So they basically mimic what would have happened in nature to clear more LDL cholesterol from your bloodstream. And they can drop your LDL cholesterol 55 to 62%. So they're really quite remarkable. And then we also have inclisiran, which, got approved in December of 2021. That's a twice a year injection that get in the office. You can't give it to yourself, but you get it in the office, and it does a similar sort of thing. It makes it so that your body clears more of the LDL from the bloodstream. But despite all these exciting things that's happened, I want to emphasize that my favorite medication of all time continues to be the statin, right? And I know there's a lot of mis and disinformation about statins. People worry about side effects, dementia, muscle aches, and all these other things, which we can talk about in the question and answer session. But I really want to emphasize that it is one of the best interventions in preventive cardiology to reduce your LDL and reduce your risk. They're the foundation of LDL lowering, and we have sort of different boxes of how much we want to lower your LDL, and that's how we decide which statin to choose and which dose of statin to choose. And the nice thing about statins is most of their side effects are dose dependent. So if you can't tolerate the highest dose of atorvastatin or rosuvastatin, don't throw the baby out with the bathwater, because it's certainly reasonable for you to be on a lower dose of that same statin where, if you don't have muscle aches or anything like that, and think about adding a non-statin therapy. So these are your non-statin add-on options. Okay, so we have currently sort of 4 options that we use. So one is ezetimibe. That's on the top left-hand corner. You can see that it's approved. It improves your heart outcomes, but it only lowers your LDL about 13 to 20%. So, I like to say how far you are from the end zone. I don't know if you guys are football fans or not, but if you enjoy football, you think about your end zone, right? How far away are you from it? Depends on whether you're going to throw the pass or you're going to run it, right? If the clock is running out and you're really far from your end zone, you're likely going to throw the pass. So you'll probably be on the right-hand side of the screen where you're reaching for one of those monoclonal antibodies, alirocumab or evolocumab, that have, 50 to 62% LDL reduction, or the inclisiran, the twice-a-year injection, which can also reduce your LDL about 50%. Now, keep in mind, inclisiran doesn't have outcomes data yet. What does that mean? That means, well, we've looked at it. It lowers your LDL. It does it safely, but we don't yet know if that translates into less heart attacks, less strokes, and less cardiovascular events. We think it probably will, because most therapies up until now that are safe and lower LDL reduce your risk of having those events, but we just haven't proven that. The trial is ongoing. But the alirocumab, evolocumab trials, we have proven that lowering your LDL is safe, well tolerated, and translates into less risk. Now, on the left-hand side of the screen, we're back to where we're kind of right near the end zone, and we can run the ball into the end zone, running, through all the line backs and what have you. And so that's your ezetimibe, which prevents absorption of cholesterol from your intestines, or your bempedoic acid, which can reduce your LDL about 20%. And that works basically on the same pathway as statins, but on a different target. So it reduces synthesis of LDL, how much LDL is actually made. And of course, you can combine both of those therapies and get about a 40% reduction. But you can see here, it's really incredible with all these tools in our toolbox that we can really drive that number down as low as possible. And I don't want you to be afraid of that number being too low, because the National Lipid Association, others, as well as epidemiologic studies have shown us that very low LDL, even if it's lifelong, is extremely safe. Remember, I told you those people were born that kind of cleared all the LDL out of their bloodstream. They had very low LDL levels. They don't have any increased risk of dementia or any kind of cognitive issues or any of the things that you hear about online. But it's nice to be able to drive that LDL down to really get people to target. And so your doctor may give you some cocktail of medications, usually what we call combination therapy, more than just the statin alone, but a statin plus something else, depending on your risk category and depending on how far you are from the end zone. But I want us to walk away from here with the message that across the spectrum, whether you're on the left-hand side of the screen, which is you have no heart disease, you're healthy, or you're on the right-hand side of the screen, which is that you've already had a heart attack, had a stroke, or had multiple events, LDL reduction is beneficial to reduce your risk of having cardiovascular disease. And the lower you get your LDL, the more you reduce your risk. It doesn't matter if you're blue, it doesn't matter if you're red. And so really, we're now thinking more and more of shifting not just the LDL lower, but shifting the population that we treat with LDL lowering. So it's not just those people that have ruptured a plaque, but also those people who are very high risk. So I'm going to wrap up with just that last section on something that I already alluded to, which is how low LDL is safe. And that's not something I want you to worry about too much. I know even some of my primary care doctors worry about this as well. And we know that we're supposed to be born with low LDLs, right? And so hunter-gatherers actually have LDLs that are a lot lower, like 35 to 70, with total cholesterol about 70 to 140. And it's really a modern urbanization thing. When we're born, our LDL is very low, and then we start to consume our lovely processed diet. And that's when the LDL numbers start to go up. So urbanized humans have really twice the level of LDL that they're supposed to. But those people who are hunter-gatherers, who are still living that lifestyle that we were sort of designed to live evolutionarily, have a much lower risk of heart disease because that LDL is lower. We also know that based on the Fourier trial, which got people's LDL extremely down because it used one of those injection antibodies on top of the statin, evolocumab on top of statin, they actually looked at people, and you can see on the left-hand side, people who got their LDL levels below 10 as compared to those that were above 100 in the blue. So you can see that those that got below 10 had more efficacy, which means something I just told you, the lower you get your LDL, the better, right? And so we make this arbitrary cutoff of 55, but some people in the Fourier trial with heart disease actually got below 10, and you can see that their risk of having an event was actually much lower on the left-hand side. Okay, Dr. Coley, it works, but is it safe? That's where you want to look on the right-hand side, where you see that safety graph, and you can see that both the red bar and the blue bar are essentially kind of head to head, right? They're neck to neck. And same thing with how many people discontinued the drug. So you got them to lower events. They're having less heart attacks, less strokes, less cardiovascular events, and the safety looks very comparable, which means that they didn't declare themselves with any safety outcome. And we know that this is a randomized trial, which is very well conducted and captures all of those outcomes. We also know that there was a sub-study that looked at cognitive function. So they took people and actually did formal neurocognitive testing, not just, oh, I forgot my keys and am I having memory issues or what have you, formal neurocognitive testing. And these were people who either got placebo, which had much higher LDLs, or people who got evolocumab, which had extremely low LDLs, with some even having LDLs below 25. And there was actually no differences between the placebo or the ones with very low LDL in executive function and working memory, in patients' self-reported things, even in cognitive adverse events such as having concentration difficulties, psychomotor speed. So everything looked very reassuring. So now, not only do we have data from the parent trial, we have data from the sub-study, which is a formal neurocognitive testing suggesting that very low LDL levels are safe and well tolerated. And we know that these levels aren't just safe and well tolerated, but they can actually are associated with a much lower risk of dementia. So when you Google LDL and dementia, you'll see all these TikToks and all these crazy things about misinformation that, oh, LDL reduction or statins cause dementia. But the actual truth is, if you look at the real data, it's the opposite. It helps us to age better because our brain is full of blood vessels. And if the small little blood vessels in the brain start to get plugged up, we can potentially have a higher risk of dementia. So lowering LDL levels are actually associated with a reduced risk of something called vascular dementia, rather than a higher risk as you read online. Now, where did that misinformation come from? Well, back in the 80s and 90s, when we used statins for the first time, we used it in older people because those were the ones that had heart attacks. And older people are the ones that get dementia. So it was just a marker of old age. It's sort of like saying statins cause gray hair. Well, no, but people on statins are more likely to have gray hair just because they tend to be older. So it's an association there, not a causation. So hopefully today I've kind of shown you that, you need to know your numbers and know your risk. Heart disease is so preventable. It starts so early in our life that we really need to think about focusing on our LDL as kind of the primary causal target for ASCVD, thinking about figuring out a risk category, which by the way evolves over the course of your life, and then deciding where your LDL target is. And that's something you should do at your annual physical every year with your doctor. We know that the new cholesterol guidelines have really recommended that lower is better for longer and faster. And we know that they, have people in the highest cardiovascular risk really need to go down to LDL levels less than 55. The good news is we have a lot of tools in our toolbox, a lot of ways that we can think about reducing our LDL. And I always tell patients you can get in from the front door to reduce your LDL with a statin. If for any reason you can't, won't, or don't want to take a statin, then you got to get in the back door. Figure out another cocktail of medications that works for you to reduce your LDL, but don't leave it untreated. So there's really a pressing need to make sure we check the LDL, make sure we target the LDL, make sure we treat the LDL. And this really needs to happen at all levels, all the way from the patient to the healthcare system to the provider themselves. So with that, I want to thank you for your attention. I hope that I've empowered you to know that how you age and how your blood vessels age is very much in your control. And hopefully you'll walk away from here thinking about your risk category. So thank you, Hilly. I'll pass it back to you and we'll take any questions at this time.
Dr. Coley, thank you so much. Just a wonderful presentation. You covered so many topics, and I think people can see why ACC chose you as the Gifted Educator of the Year. I mean, just really taking complex topics, boiling them down to something that is simple. So thank you for that. I'm so glad that we kind of ended on the dementia topic. So we get that one all the time of, how low is too low for LDL? Is there the association with LDL and statins and dementia? And so we did get a question on that. I thought you handled it really well in the main presentation. But any other final thoughts on kind of why people shouldn't be concerned about having a low LDL?
And I'll just make one more comment, which is that sometimes I do get patients that I start them on a statin and they say I'm just a little more foggy. And if you think about the statins, we have two different types. We have many different types, but the two kind of workhorse statins are your atorvastatin, rosuvastatin. Atorvastatin dissolves in fat, it's lipid soluble. Rosuvastatin dissolves in water. It's hydrophilic, it's water soluble. And so sometimes I'll notice that patients will tell me I'm a little more foggy on atorvastatin because we know that when it dissolves in fat, it can affect the blood-brain barrier, which is the little barrier around our brain that keeps, cholesterol medicines out of the brain. So I'll switch them to the other kind, and a lot of that will go away. Now, people say, well, doesn't your brain need cholesterol? And this is another question that I get all the time. And the answer is yes, it does. And in fact, it needs it so much that it makes its own cholesterol. So I want people to know and be reassured that if they take a cholesterol pill to lower their systemic cholesterol, it just means it's not blocking up your arteries and getting stuck in your arteries. It doesn't mean that your brain is being deprived of cholesterol. You still have the ability to make it. And most of these medications do not cross the blood-brain barrier. They don't get into your brain and affect the brain's ability to synthesize cholesterol.
Oh, it's really so helpful. And, I think it's also appreciate the fact you took on the idea that the average LDL in America, which is 120 or 130, is not a normal LDL cholesterol. And so it really, at the very least, getting it under 100 is important, and the lower, the better, and lower, faster, longer.
You got it.
Yeah, exactly. One of the questions that came in was kind of, at what age, so if you have controlled hypertension and your LDL is that average Americans of 120 or 130, at what age would you think about a coronary calcium score to kind of begin to identify whether or not, that average LDL, which is not a good LDL, has actually led to something?
I started to do coronary calcium scores at the age of 40. Now I want to spend a minute just talking about a coronary calcium score because it's like an X-ray, a non-gated CT scan of the heart. And what it shows is calcified calcium deposits that are stuck on top of plaque. Now I want to be clear that it doesn't show us how much plaque you have. It doesn't tell us exactly how much plaque you have. Generally, your calcium score does correlate with the burden of plaque, but you could very well have soft plaque that's not yet hardened or calcified that will not show up on a calcium score. And it usually takes plaque 5 to 10 years to calcify. So I say sometimes getting a calcium score is kind of like looking at the stars. It's looking backwards in time. It's looking at plaque you may have put down 5 or 10 years ago that's now hardened, matured, and calcified. And ironically, calcium scores pick up calcified plaque, which is the happier type of plaque. They don't tell us about soft non-calcified plaque, or what's called low attenuation plaque, which is the angry plaque that's more likely to rupture. So I do get a calcium score at the age of 40. And then every 3 to 5 years after, if you get a score of 0, which is the best score that you can get. But the thing I keep in the back of my mind is if somebody has a calcium score of 0 in their 40s, the negative predictive value, meaning, okay, they don't have heart disease, is a lot lower. Now, fast forward to someone who's 75 years old, has had many decades to calcify their plaque. If I get a calcium score of 0 in your 70s, now suddenly I'm feeling a lot better because that 0 means a lot more. The power of 0 in terms of predicting your risk is much higher when you're older than it is when you're younger. So don't get faked out by a calcium score, but I mainly start to get them in the 40s because if somebody has anything but a 0, and I actually have a good friend, ironically, she's a cardiothoracic radiologist, she has a calcium score of 2 at the age of 42. Now, that number may not seem that high, but she's a young premenopausal woman who's already got a calcium score of 2 at the age of 42. And of course, you look at her LDL numbers, they're about 130, 140. I'm jumping up and down, right? Because she's already put down plaque in her 40s, probably in her 30s, because it's calcified already, and I need to be aggressive.
It's a great answer. I'm so glad that Cecilia asked that question because we've talked about my experience, Dr. Coley, but I was that person who at the age of 50 controlled hypertension, always had LDL in the 120, 125. I had a coronary calcium and it was 10. And I thought,
Wow.
oh, 10, that's pretty close to zero. No need to worry, no need to do anything. And I had it repeated, as you recommended, 5 years later and it was 125. And so I
Yeah.
had lost 5 years when I actually could have been doing something, and now I'm on a statin and my LDL is 35 and I'm taking action based on it. But if you're going to do it, it's important to actually do something with the results and take it to your clinician and really have a conversation around that. So yeah, that's just it. We get a lot of questions too about the role of coronary calcium and what to do with the information. So that's
And I'm
great.
just glad we're using it more because I feel like, I wish insurance would cover it. Unfortunately, it's still not covered. It's an out-of-pocket test, but I can't emphasize enough how important it is to think about getting it proactively because you don't want to wait for that heart disease to manifest, just like you said, Hilly. And congratulations on getting that LDL down to 35.
Thank you. And I still remember where my keys are. So that's another good thing,
Okay. That's good.
even on my statin. And it was great to see in the new cholesterol guidelines that they actually had very specific recommendations based on the coronary calcium, that, depending on what it is, the LDL cholesterol goal gets lower and lower the higher the coronary calcium gets. So
Yeah.
that was really exciting to see. Another question we get a lot is just around HDL cholesterol, which was very fashionable 30 or 40 years ago. If your HDL is high, it's protective, or people were calculating ratios. Thoughts on that?
Yeah, so it's interesting because we've changed our thinking around HDL and ratios quite a bit in the last few years. And too much of a good thing is a bad thing. And we've realized that actually too much HDL can count against you. Now, what's considered too much HDL? Well, we don't exactly know where that inflection point is. We know if it's too low, it's bad. And that's usually, less than kind of 40, I would say, for men and probably less than 50 for women. And then if it's too high, and that's usually around maybe 90 to 100, we don't quite know. We think it might be dysfunctional. It actually confers more risk. So a lot of times people get faked out because they have this very high HDL in 90s or 100s or what have you, and that their ratio looks very favorable. So that's definitely not what you want to do. The other thing you don't want to do is say, okay, just because the ratio is good, I'm going to ignore the bad guys. So I always like to say, think about it like you're fighting a war. So let's say your HDL is 82, which is a pretty good HDL for most people, but your LDL is 130. You got 130 bad guys, and you've only got 82 good guys, right? And so really, ideally, if you are going to look at that ratio, you ideally want to try to invert it so that you have more HDL than you have LDL. But again, with that caveat that too much HDL can be bad and too little HDL can be bad. So it's a U-shaped relationship. So I look at HDL as kind of my third line. I first start by looking at the LDL. That's the first number that I always look at. Triple digits bad, double digits good, heart disease lower down to 55 or what have you. And as you said, Hilly, if you have coronary calcium, the higher the coronary calcium, the lower that LDL needs to go. The next number I actually look at is non-HDL cholesterol. So that's all the other bad guys besides the LDL, right? So that's something called IDL, intermediate density lipoprotein, VLDL, very low density lipoprotein, all of the other particles that cause blockages to occur inside our arteries that we can sometimes miss if we just focus on LDL. And a better metric of that is a separate test called apolipoprotein B or ApoB. We don't always get that on a standard lipid panel, so sometimes I'm left interpreting without it. But my second look is that non-HDL cholesterol. So I hope that you and everyone on this call knows their non-HDL cholesterol because that's an important number to think about. And then third, I look at that HDL and I count it against you if it's too low or too high, but I don't give you a ton of credit if it's kind of in the normal range. And then I look at those triglycerides and I say, okay, if you're fasting, they should be less than 150 or ideally less than 100. If you're non-fasting, they can be a little higher, but they confer risk, with that risk being even higher for women.
That's great. And we do get a lot of questions around non-HDL cholesterol. And so just for the audience, it's super easy to calculate. It's just the total cholesterol minus the HDL cholesterol, and that's your non-HDL. And if I'm right, typically the goal for non-HDL is about 30 above the LDL goal. So if your LDL goal was 55, it would be 85 but it's a very simple thing to calculate, and it really is also incredibly predictive.
Mhm.
Great question on, and I'll just ask a couple last ones. I know we're getting close on time, but for
Yeah.
somebody with a really high lipoprotein A, we spent most of the time talking about LDL, but for if somebody has an Lp little a over, let's say 200 nanomoles per liter, what would you target for an LDL cholesterol in somebody like that?
The dose-dependent relationship with Lp little a or lipoprotein A is also pretty dramatic, and the higher it is, kind of the more cardiovascular risk you have. And really, as you said, Hilly, I lower the LDL even more because what is Lp little a? It's basically an LDL particle that has an arm on it, and essentially it's atherogenic, so it causes plaque. It's also pro-inflammatory, so it causes inflammation, and it's also prothrombotic, so it can actually create blood clots inside the artery as well. So it's sort of three bad guys rolled into one, and it's 70 to 90% genetically determined. So it's not how much exercise you're doing, what you're eating, none of those types of things. Certainly after menopause, ladies, it can go up a little bit. So some of that can be a little bit modifiable, but not that much. So I usually drive those people who have an LP little a less over 200, I would drive them down to an LDL less than 55. So I call these target signs. And what I want us to do is to think about what target signs we have for heart disease. So if I'm talking about myself, I'm South Asian, which is a target sign. I have a family history of heart disease. And when I started myself on a statin, my LDL was around 130. And so those are my three target signs. Now, of course, as I get older, maybe I'll get pre-diabetic, past menopause, maybe I'll get hypertension, maybe I'll put on some weight. These are all additional target signs that we may accumulate. But think about all those target signs. The more target signs you have, the lower you're going to drive your LDL. So if my LP little a was normal, I would be less than 100. The fact that it's not just normal, it's 2, 3 times the upper limit of normal. In your example, I'm going to bring them down to less than 55. Now,
Okay.
I'll quickly say there's some data as well to think about using aspirin to prevent heart attacks and strokes in people who have very high LP little a's. Now, don't start that without talking to your doctor, of course, but ask your doctor if your LP little a is really high. Does it make sense for you to think about starting an aspirin before you've had a heart attack or stroke?
That's great. Maybe the last question I'll ask comes from Sarah, and it's a really, I think, thoughtful question. And so it's kind of a two-parter, one for me and one for you. But it's with all of the great new tools in the toolbox and all the excitement, what can we do for the underserved populations to make sure that access is there? And at least from the Family Heart Foundation side, that's one of the reasons why we launched the Cholesterol Connect program, which was, it's a program that's absolutely free. You don't have to go through insurance. And so anybody can assess their full lipid panel, LDL, HDL, triglycerides, calculate the non-HDL and the lipoprotein A for free. And it's a simple finger stick that individuals can do at home. And so that, at least from our side, we're certainly always trying to work to improve access, reduce prior authorization, things like that. But so that's kind of from the family heart perspective. Any thoughts from a clinician perspective, Dr. Coley, of how underserved populations can benefit from all of the great revolutionary therapies that are coming?
Being underserved, Hilly already puts a big target sign on you right there. And in fact, the Prevent Calculator, which is that newest risk calculator we talked about even incorporates your zip code, because it does talk about these what we call social determinants of health, and how things we didn't normally think about increase heart disease risk, they increase it. So not only are these the highest risk populations, to your point, they have the least access to care and to testing. I will say I have used Cholesterol Connect all the time in my patients who either don't have insurance or patients who are on these very high deductible plans where you got to pay all this money out of pocket and insurance may or may not cover it. Because the first step is education and empowerment. If you get your numbers checked for free and you put them into the Prevent calculator, you have your blood pressure and your cholesterol, your LP little a, what have you, you can at least figure out which risk category you need to be in. And then the nice thing is most of these medicines that we talked about, whether it be statins or ezetimibe, are generic. Obviously, the other medications are more expensive, but there are many different foundation programs. I don't know if Family Heart has one, but certainly each of these companies that manufactures these medications has income programs where they'll send you free medicines if you're below the income threshold. And Medicare has one of their own that they work with the Social Security Administration. So if you fall below this income threshold for poverty, all your branded meds, not just your cholesterol medications, are actually completely covered. So I would say don't let that deter you. If you're uninsured or underinsured, take the first step, get the numbers checked, calculate your risk, and then let's figure out how to get you treated, because where you live shouldn't determine how long you live. And that's one of the hardest things that I've had to grapple with as a physician, is how do you level the scales so that everybody really has access to be able to live long and live healthy lives like we all want to.
Oh, well, such a great answer, and I'm so glad we closed with that. And so, Dr. Coley, thank you again so much. We have a couple of just wrap-up slides that I'll get to, but I can't thank you enough. The comments that we're getting are really just fabulous. People love the presentation, love the amount of information you covered, and the way you covered it. So,
Thank
on
you.
behalf of everybody at Family Heart, thank you.
Thank you.
And so just to close things out here, as I mentioned before, we do have a care navigation center. And so if you're struggling a little bit with the way that you're being treated, or you feel like, oh boy, I could probably get better care, we have three wonderful care navigators. And so I would really say take advantage of this, reach out. They're a wealth of information, referrals. And so please feel free to visit our care navigation center. On the next slide, just a reminder of Cholesterol Connect. We certainly have talked a lot about that, but so far we've sent out over 30,000 test kits absolutely free, no insurance required. It's a great way to start your journey on to better cardiovascular health. And the next slide. So we're a nonprofit patient advocacy organization, and we really appreciate any and all donations. Even $1 makes a big difference. And so if you are so moved, we would really appreciate any donations that you might make. And then on the last slide, again, a big thank you to the audience, to everybody who joined us, and especially to Dr. Coley for what's such a wonderful presentation, and wish you all a wonderful evening and good cardiovascular health.